Hello, and welcome to a new edition of Health Matters, a show about what matters in your health here in Central Massachusetts. My name is James Broadhurst. I'm a family doctor. I represent the Worcester District Medical Society, which does, in partnership with WCCA TV, channel 194 on your cable dial, produce this show. This show is a little different than some of the ones that we've done in the past. Normally, you might be tuning in and learning about something new, disease or treatment, or a public health issue that people are trying to address in new or innovative ways. What's different about this show is that we're going to be talking about how primary care services are delivered to patients and what models now exist for that. My guest is Dr. Tatiana Hamawi. She is a physician trained in combined medicine and pediatrics. So you're board certified in both of those disciplines. And your training started at Mount Sinai Hospital in New York City, as I understand it, and then you went upstate to Albany, New York, and did your medicine pediatrics residency there. Is that right?
That is correct.
I wonder if you could start, before we start talking about models of care, just tell me a little bit about medicine pediatrics and how that fits in the larger array of doctor specialties.
So medicine pediatrics, or MedPeds for short,
Right.
is a specialty in itself.
Mm-hmm.
When we finish medical school, we have our medical degree. If you finish 1 year of training, you can go out and work.
Right.
But if you become board certified, then you have expert training. And internal medicine is for adults.
Right.
And pediatrics is for children.
It's for kids.
And
Right.
it's a little bit different than family medicine in that it requires 2 separate boards and an extra year of training.
Right, okay. So,
And it does not involve the obstetrical training that often happens in family medicine boards.
right. So when our listeners are thinking about, I went to a doctor and they're a surgeon, or they're a neurologist, or they are a family physician, in your case, they are going to someone who's board certified in both medicine and pediatrics and fully trained to take care of somebody from cradle to grave, I guess.
And for simple routine health visits as well as chronic care management.
Right. Now, my understanding, as we were talking before the show started, you've been in practice in Worcester since 2002?
Correct.
Is that right? I wonder if you'd be willing to share a little bit about your journey, because I understand that you were in a kind of traditional private practice, and then you more recently have moved into something called direct primary care, or
That's correct, direct primary care.
direct primary care. Let me preface this a moment by saying, from my perspective, you're a brave physician.
Thank you.
Because it is far more common these days for a physician to finish their residency training and then choose to go to work for a larger company, organization. And in Worcester, at least three come to immediate mind. There is the Reliant Medical Group, there's the St. Vincent Medical Group, and then there's the UMass Memorial Medical Group. And doctors can work within these systems, but they are paid, they're employees. And you may have had some early experience in that, but you chose, since 2002, to be your own boss. Is that right?
That's correct.
Right.
I did.
Tell me a little bit about what that's like in terms of running a business.
So I'm very entrepreneurial minded, and when I started, there were a lot of other doctors in private practice. There
Right.
was an organization that we belonged to that would help us contract with insurance companies. But as the years went by, I think somewhere between 30 to 60% of people left private care and went to work for these larger agencies. And things that got in the way of them running their own practices were the advent of the electronic medical record, which required a huge capital outpouring for physicians. And a lot of the older physicians who had their private practices would rather retire than invest that new money. With insurance increased requirements of management and paperwork and everything, a lot of the physicians didn't want to have to operate that way and chose to go to work for the hospitals where they could just do the doctoring and not have to worry about the overhead
Right.
and all those requirements. And I have always been independent minded and wanted to stay, and I have managed through all these years to stay in private practice under the health insurance model.
Right.
For about it's a year and a half now that I have gone to the direct primary care. So for about 20 years, I was in the insurance model.
Okay.
And I'm currently transitioning away because I'm feeling as though my ability to stay in private practice is threatened by all the requirements of the insurance companies. And my only way to continue in this model is to go to the direct primary care model.
I remember in our practice lifetime that the Medicare system announced that it would no longer accept a paper bill for services from a physician. And that, I think, was one of the things that made it absolutely certain that you had to have a computer and an electronic medical record in order to bill and get paid for the services that you provide. And as you say, those are terribly expensive. I think our listeners, probably most of them, are living in this model of in health insurance where they get health insurance maybe from an employer or perhaps from the state in the sense of Mass Health or from the federal government in Medicare. What's it like from the physician perspective in that model? How does it work? A patient comes in to see you.
In the
and you
insurance
provide
model or the direct primary?
No, the insurance, we're going to just review that very quickly.
So what's it like? It's burdensome. There is a lot of overhead, and they keep adding more and more requirements that pull us away from the time that we can give to our patients. There's more administrative work.
I see.
Referrals, for example.
Right.
You used to have networks where your patients, as long as they were in your network, you didn't have to process a referral. Now everybody needs a referral for everything, including nowadays a simple colonoscopy, which is a standard screening procedure.
Right.
So the more and more they add that administrative burden, the more people we have to hire to do that work. And they've taken our tools away, and that's a longer story, but it's in long run, it's a lot of money. And then that means we have to hire and pay for the staff to do that. So in order for me to pay for the staff to do that, I have to see more people, and that means more people get squished into a day. And then what happens? Each patient gets less and less and less time. And so the way you make money becomes on volume and not on quality of care and time that you spend with your patient.
So here you are spending 20 years in this system, which is the system that most physicians are in. The ones who are employed say, well, I'm going to let the business office take care of that, and I'm going to let the people in the capital budgeting arena figure out how much we're going to have to spend for computers and upgrades and all that kind of stuff. So in the individual, you have to generate all of that revenue in order to support the business. So how did you learn about direct primary care, and how were you I don't know, brave enough to decide that you wanted to switch to that model of care?
I tell you, I wish that I had learned about it in about 2014 because I was looking for something like that back then. But back then there was only something called Concierge Medicine. And for me, that was too expensive for the patients, and it didn't separate away from the burdens of the insurance companies because the concierge medicines still bill insurance. So the patients are still on the hook for deductibles and copays, plus they have the fee for the concierge. And I just couldn't make that fit way back in 2014. But recently, a couple of years ago, a patient came to me, and at that point I wasn't taking Medicare because of it was too much overhead burden for me. And she said to me, Dr. Hamawi, I'm not leaving you. You need to do something about this. And one of my colleagues introduced me to the concept of direct primary care. And I said, wow, that is a direct match for exactly what I need. And I adopted it, and I have never looked back, and I love it. So I'm still transitioning slowly. By the end of this year, I will be fully direct primary care and no insurance. But that's how it came about.
Maybe
a patient asked, and a colleague provided the answer.
Exactly. So now take us back, the listeners and myself, to that time a couple years ago when you're having a conversation with your colleague. What did they describe? What is direct primary care?
So direct primary care is a unique model of providing primary care services on a membership basis.
Okay.
And what it does is it removes the insurance company from the doctor-patient relationship. It returns the patient to the customer. The insurance is no longer my customer, okay? The patient is my customer, and that's the way it should be. I am in the insurance model, trying to please the insurance company all the time. And for me, that's not the oath that I took. That's not the way that I want to practice medicine. And this allows me to completely focus my attention on my patient, design the visit according to the patient, take care of the patient in between visits without having to worry about, well, the insurance not going to pay me for texting them or for checking on how well they are. I can do little things for them, and I can keep them at their job and still help them, save them time by doing things that now I'm in control of, and before the insurance company wouldn't let me do.
I see. Okay. So the way it works is that a patient pays a fee at some time, I guess every month?
It's a monthly. Some of them offer it as an annual.
Oh, I see.
I prefer the monthly because it's easier for patients to budget.
Okay.
And it's a very low fee.
Now, and we'll come to some of those issues in a moment, but that patient still, I guess, has, and I think maybe still needs to have some kind of health insurance. Is that right?
Yes, they need a health insurance to cover catastrophic conditions, to cover the hospital, to cover if you need a specialist, if you need surgery, if you need to go to the ER. So you need some kind of catastrophic plan. If you picture your house insurance, okay?
Right. Okay.
When you buy your home insurance, you buy it to cover something you hope will never happen.
Right.
And you never use it.
A fire, a flood.
Exactly.
A tornado, a hurricane.
Exactly. You never want to use it. And if you use it, your premiums are going to go up. If there's something small, you repair it. You go to Home Depot or wherever, and you shop for the best price, and you fix what needs to be fixed. And you maintain it, and you pay for that maintenance. Okay? If your house insurance would cover all the maintenance and all the repairs, just imagine how expensive that would be.
I see.
So it's the same model for health insurance.
Okay.
Why would you insure your primary care? You know you're going to need a physical. You know you're going to need, maybe treatment for a urinary tract infection or poison ivy or something that came up.
Or a sprain or a strain. Or
yeah, why would you
things that
insure something like that? You should be able to shop and compete for good prices for things like that. And you should be able to have access to your doctor when you're healthy. Our current model only treats you when you're sick.
Right. Let me just hold that thought for a moment, and I just want to remind our audience that you're listening to Health Matters show of the Worcester District Medical Society and WCCA TV. My name is James Broadhurst. I'm here with Dr. Tatiana Hamawi, who is helping us learn about the direct primary care model of delivering primary care. So, in the direct primary care model, the patient is going to a physician, and the patient, it sounds like, is setting their agenda within the context of your professional training and your knowledge of kind of what human beings need from a primary care perspective. Is that right?
That's right, and each patient is individual. It's what's right for one patient may not be right for the next patient. And in the current health system, as I mentioned, they treat you only when you're sick, and they treat you according to protocols. And the physicians don't have the liberty of time to hear what it is the patient needs and wants, and their cultural backgrounds and everything that is important to them. In our model, we have time to sit and listen to the patient. We can also get them in very quickly and, spend more than 8 minutes. They get an hour visit. They can come in on same day or at least the next business day.
Right.
And they have access to me in between visits via texting. And so it's so much more tailored individual person.
I see. So in the employed physician model, you were mentioning that part of what you need to do is to see some number of patients in order to generate the revenue that supports your salary, I guess is one way of saying that. Whereas in the direct primary care model, you decide based on your professional time and circumstances how many patients you're going to have in your practice. Is that?
That's correct. Even in the insurance model, I managed to keep my overhead low enough that I could see about 40 people a week. Some of the physicians currently in employed models see anywhere from 25 to 40 patients a day.
I see.
And in the direct primary care model, my panel was about 2,000. In the direct primary care model, our panels can be about 400. So imagine how well we can take care of those 400 patients.
Right. I went to the website of the American Academy of Family Physicians, and they have some information about direct primary care. And one of their surveys said that the average size in a direct patient care model is about 413 patients. And I think I saw that in a week, it was the average number of patient encounters was 41 or something like that. Whereas
Correct.
You're saying on a busy day, an employed physician, primary care physician, might be seeing 40 patients in that one day.
Yeah, that would be an extreme, but typically 25 to 30, yes.
Right.
And so they don't have time for each patient. There isn't enough time in the day.
And because the overhead is much more controlled and much less, you don't have to, you can take your time with every patient.
We can.
Yeah.
And that's the deal. Because we want to restore that doctor-patient relationship. We want to stay in touch with patients. We want to help them stay well. If we do our job well, they actually don't need to come into our office. We keep them healthy.
Right. So what are you hearing from your patients about their experience in direct primary care?
So the patients who have joined love it. They love it. I'd like to tell a quick story. I had a patient who, she was my patient, but she wasn't able to make her monthly payment. So she decided to go to the urgent care and then to the ER and then to the ER. And she wasn't really worried about those bills because I don't know if she was going to pay them or not. But I said, okay, you couldn't pay me. Why don't you call me? We could have made an arrangement. And in all those three places, they couldn't help her. She had pain in her arm all the way up here. And they couldn't figure out what was wrong because they don't have time to listen to her whole story. And the ER's job is not to listen to your story, but to make sure you're not going to be harmed in the next 24 hours. They worked her up for a heart attack.
I
Well,
see.
she came to my office. I sat and I listened to her whole story. And then I just touched her arm right here, and she was exquisitely painful. I said, well, you have a tennis elbow. I gave her an injection,
Yeah,
and she said, Dr. Hamawi, that's the first time I've been able to pick up my purse. That's the first time I've been able to squeeze my hand. Thank you
Right.
so much.
and that certainly points out that if care is fragmented, if you have to go from one place to another place to another place, it's difficult to coordinate care and have that sense of getting the whole story. But that seems to me what you try hard to do.
Yes, and over time too, we develop long-term relationships. We're like part of the family to this patient. And over the years, we build that trust, that bond, that family relationship, and they can call us just like they can call a family member when they need something.
Are there aspects of direct primary care that we haven't talked about yet that you were thinking that we ought to touch on?
A long time ago in medicine, doctors used to call each other. Doctors used to pick up the phone and say, I have a patient, here's the story, what do you think, and can you do something? Right now, because those physicians are so busy, they don't call each other anymore. And I have another story. I had a patient who had a new onset atrial fibrillation, which is a problem with the heart.
Right.
And to try and get an appointment with a cardiologist was going to be sometime 2 to 3 months from where I was calling. And I couldn't get past the front desk because they just don't have the liberty to make those exceptions.
I see.
I made a doctor-to-doctor call and explained the story, and of course the doctor made an arrangement to get that patient in right away because it doesn't make sense to wait that much time.
Right, right. You mentioned before about something simple like colonoscopy, and that's something that is routine, but it's not something that you or I do. At least I don't do them. I'm assuming that you don't do colonoscopies. Right. So how does it work when your primary care patient needs something that is routine, but is frankly quite costly in the sense that a colonoscopy, there's a charge for the doctor who actually does the colonoscopy, but then again, there's the anesthesiologist that's providing the sedation and the colonoscopy suite office where nurses are checking you in and then monitoring you before and after the procedure. I know that the whole package is pretty expensive. I would put it probably in the thousands of dollars just out of pocket. Now, how does it work that somebody sees you for primary care, in direct primary care, and pays a monthly fee, and then does the colonoscopy just get billed to their insurance? And it gets paid however their insurance is going to pay for that.
Yeah, so for any imaging or procedures, you can choose to go through your insurance. So something like a colonoscopy, as long as it's a screening and not a diagnostic, you will probably have it covered by your insurance. If it becomes diagnostic, you will only get it covered after you have met your deductible.
I see.
But there are other things like images, an MRI. You can choose to put it through your insurance. And unfortunately, things that go through insurance get marked up. So for example, you want an MRI of your wrist. An MRI of the wrist will cost $2,000 or will at least be billed $2,000 to the insurance. It might get dropped to $1,500 because you have an insurance contract, and it gets pushed to the patient until their deductible is met. Guess how much I can get an MRI for you? I can find an MRI cash for anywhere between $300 and $400 for your wrist. So would you like to go through your insurance to pay $1,500 for a $300 MRI?
So does that mean that as part of your work in direct primary care, you actually go out and negotiate fees,
Correct.
cash fees with, laboratories and imaging
So we do it
places
with
and whatnot?
laboratories. There's not a lot of imaging in Massachusetts, but I have knowledge of ways to get it in nearby states. So yes, we can provide savings through means like that, as well as with pharmaceutical companies where we can get discounts on medications. In some other states, the doctors are actually allowed to buy generic medications and dispense them in the office. In Massachusetts, you're not allowed, but you're able to make a contract with a vendor and get generic drugs cheap for patients.
So, I mean, from the physician's point of view in direct primary care, while you're freed up from a lot of the third-party payer stuff, it sounds like you have to spend a fair amount of effort in developing those relationships to support your patients with diagnostic studies, whether it's laboratory or imaging or whatever. I mean, or maybe that doesn't take very much time.
It doesn't take that much time. You know,
Okay.
it's a little bit of effort, and it brings tremendous joy because it brings value to what I can give to the patient.
So we're going to be wrapping up, but I wonder if you can just talk a little bit about the affordability of the direct primary care model.
So it's very affordable. Imagine if you had, your movie subscriptions
Okay.
and you paid for every movie. You would probably not watch movies or go to the movie. It's such a nice model to pay a very low fee every month, and then you get what you need.
I see.
Right? It's the same thing in direct primary care, and it's very affordable. It goes anywhere from $50 a month to $125, depending on the practice, and depending, some will charge by age, and some will charge a flat fee. Like I charge a flat fee, and I give a discount if you bring family members.
Right.
And so it's a very low and a very predictable cost, and everything is transparent. You don't have to worry about a surprise bill anywhere.
Oh, that's a good point.
Right.
Because sometimes
So you can budget.
you get a bill out of the blue from someone that you didn't even know provided a service.
And where you have the savings are in you switch your insurance to a high deductible plan with a lower premium,
Yeah.
and then you spend the money on your direct primary care, who effectively takes your high deductible and reduces it to a low deductible. And on the chance that you have to have that fire or that flood,
Right.
every year that you're not paying that out, you're saving
You're
money
saving
and
that
putting it in
money.
your pocket.
Well, I want to thank you, Dr. Hamawi, for taking the time to help our audience understand about direct primary care. It sounds like an exciting, different, alternative model of care. And it seems with an experienced physician, you can get it to dovetail with the existing insurance in order to handle those catastrophic or those higher cost kind of issues. So thank you.
Thank you for the opportunity. I would love to come back and explain more if your audience ever has any more questions.
Terrific. Well, I want to thank you for joining us for this edition of Health Matters. My name is James Broadhurst. I'd like to thank our engineer, Frank Rocco, for making this show technically possible. And I'll invite you to join us for another edition of Health Matters next time.